Hello, my name is Ai-ris Yonekura Collier, and thank you for the invitation to talk about COVID-19 vaccination in the pregnant and lactating population. So I'd like to introduce the conversation of vaccines in pregnancy by introducing the morbidity that COVID-19 disease causes in pregnant patients. So we know from the CDC data that pregnancy confers a greater morbidity and mortality from symptomatic COVID-19. In this study comparing hospitalized symptomatic pregnant people with COVID-19 and symptomatic non-pregnant women of reproductive age, there was a higher rate of ICU admission, higher rates of mechanical ventilation, higher rates of need for extracorporeal membrane oxygenation, and higher death rates in pregnant people compared to non-pregnant women. So some of the most recent studies demonstrate that when you compare infected to uninfected pregnant patients, there are higher rates of maternal death, higher rates of pregnancy complications such as preeclampsia, preterm birth, and stillbirth. And there are consequences for the newborn, including increased rates of NICU admission. In some of the more recent studies done that compare just symptomatic to asymptomatic COVID-19 in pregnancy, we do know that severe disease in pregnancy leads to a higher rate of cesarean birth, higher rates of preterm birth. Many of these are iatrogenic and not spontaneous preterm births, higher rates of hypertensive disease, small for gestational age infants, and a signal of higher rates of neonatal or fetal demise and thromboembolism in pregnancy. So with this data, we know that it's very important to provide prevention mechanisms for COVID-19 during pregnancy and during lactation. Aside from the common standard recommendations of masking, distancing, and avoiding crowds, there are data for vaccination in pregnancy and how that protects both the pregnant person and their newborns. And I should say that, at least in the US, all of our governing bodies highly recommend the use of COVID-19 vaccination for all pregnant people. Some of the data behind this, I know initially pregnant people were not included in the initial phase 3 studies for COVID-19 vaccines. This is data provided by the CDC looking at both on the top row, Pfizer vaccinated, mRNA vaccinated individuals. And on the bottom row, there's Moderna mRNA vaccinated individuals. And here is just comparing the local and systemic reactions to the first and second dose. The first dose is in the left and the second dose is in the right. The dark blue is looking at the rates of reactogenicity in pregnant people and in non-pregnant reproductive age women in the light blue. And I just want to point out, a lot of my patients were initially quite hesitant to get the vaccine because of some of the symptoms, including fever during pregnancy. And I would say the rates of reactogenicity are actually pretty similar, both after the first dose on the left and on the second dose on the right here. And although no statistics were done on this data, as it was an observational trial and that was not powered for this, there does appear to be a signal of lower fever rates in pregnant women compared to non-pregnant. Furthermore, our lab and others have demonstrated that since the emergency use approval of vaccines for COVID-19, the first few pregnant people who received vaccinations had similar immune responses after vaccines compared to non-pregnant individuals. We also looked at a group of lactating individuals, primarily looking at a couple weeks to 4 weeks after the second dose of mRNA vaccine. And on this middle graph here, you can see in black is the neutralizing antibody titer for non-pregnant reproductive age women. In blue, the neutralizing antibody titers were quite similar for pregnant individuals. And in orange, this is lactating individuals. And all those levels were very similar. And interestingly, these neutralizing antibody levels were much higher than those both non-pregnant and pregnant women who received no vaccine but had a recent COVID-19 infection. On the right here, I think is a lesser studied metric is T cell function, and T cell function that was raised after vaccination in both pregnant, non-pregnant, and lactating individuals. And the T cell responses were similar across those three groups as well. So this further gives justification that pregnant and lactating individuals launch a similar response to mRNA vaccination compared to non-pregnant. But what is the real world efficacy of vaccines in pregnancy for COVID-19? This is a large study. It was an observational cohort where over 10,000 pregnant vaccinated people were studied, and they were matched to 10,000 pregnant unvaccinated individuals who had no known history of prior infection with SARS-CoV-2. In this 10-week follow-up, they followed infections. There were 131 in the vaccinated and 235 in the unvaccinated group. And using this data, they were able to calculate that vaccine effectiveness was 89%. And this is in particular against hospitalization and severe disease from COVID-19, which are one of the most important clinical metrics that we look at. This followed pregnant people about 1 to 8 weeks following the second dose of vaccination. But here's another thing is in pregnancy, we're not worried just about the pregnant individual. We're also concerned about the fetus and newborn. And there is a large gap in terms of the population where vaccinations are available. In fact, right now, we don't have available vaccines for kids under 5 years old. And certainly no vaccines are even being tested in clinical trials for infants between the ages of 0 and 6 months. So what do we know about the ability of vaccination in pregnancy to provide passive immunity? We know that initially after newborns are born, they have a relatively immature immune system and often rely on the passive immunity from the pregnant mom. And this happens through transplacental antibody transfer of maternal vaccine antibodies to the newborn through the placenta. And these antibodies can be detected at the time of birth and actually can be detected in infant blood for out to 6 months. The amount of antibodies transferred from mother to fetus depends on both the maternal antibody concentration, which is one of the reasons why we often recommend vaccination during pregnancy or booster vaccination for things like pertussis during pregnancy. And it also depends on the gestational age at delivery, the fetal weight, and also the antibody glycosylation status. So I would mention that, some of my patients who are pregnant want to delay vaccination till closer to birth, but I would recommend that they get vaccinated with a little bit of time for their antibodies to mature and have the appropriate glycosylation that confers efficient transfer of antibodies from the maternal side to the fetal circulation. And just to mention that this is not a new concept. Maternal vaccination was developed as a strategy to mediate infant vulnerability to other pathogens, including pertussis using the Tdap vaccine and influenza using the influenza vaccine in pregnancy. So our group and other groups have demonstrated that there is efficient transplacental antibody transfer from the mother to infant following vaccination. So in this slide, we're demonstrating that in vaccinated individuals, in black here on the leftmost, the levels of serum antibodies specific to the SARS-CoV-2 spike RBD are transferred and detected in infant cord blood at the time of delivery. And this is transported at much higher levels compared to when you have pregnant individuals who are infected but unvaccinated, kind of on the right here, demonstrated lower maternal serum antibodies and less levels of transfer of antibody. On the right plot here is a similar patients, but looking at the functional neutralizing antibodies which were transferred. And here we're again demonstrating that there was robust humoral immunity elicited in both maternal serum, and that was efficiently transferred over to the infant cord blood at delivery. And others have demonstrated that this transplacental antibody transfer, the rates were higher in vaccinated individuals compared to after natural antibodies transferred after natural infection. This is a slide done by another group, by one of my colleagues, Malavika Prabhu, who demonstrated that there is a time-dependent response of the transplacental transfer ratio. And when you look at time elapsed from the first dose of mRNA COVID-19 vaccine, you don't always see passive immunity in the infant cord blood until at least 2 to 3 weeks after vaccination. So that's another reason why I recommend not waiting till 37 weeks of pregnant to get vaccinated. You have to wait earlier to get that good maternal immune response and then the efficient transplacental transfer. And so, the longer duration from being fully vaccinated to delivery appears to improve transplacental transfer ratios. So those were all time points looking at just at the time of delivery. But what about how long do those transplacentally transferred antibodies last in the neonatal circulation? This study looked at both vaccinated individuals. I would pay attention to the black dots there, right at the time of delivery, and then at 2 months, and then at 6 months after delivery in the neonatal blood. And you do see kind of a durable immune response, the antibodies, out to 6 months in infants after vaccination. By comparison, in orange there are infected individuals at both delivery and at 6 months. And you do see that the passive immunity is less durable after just natural infection and not vaccination. And there's further clinical real-world evidence for the effect of vaccination in pregnancy on newborns. And this study by the CDC demonstrated that maternal vaccination was actually protective for infants less than 6 months for admission to the ICU. I should also mention that there's robust passive immunity provided through lactation. We know that antibodies can be transferred through human milk. And vaccine antibodies have been detected in human milk after vaccination during pregnancy or vaccination of lactating individuals. Here, I'm just demonstrated that we were able to detect predominantly IgA antibody transfer into human milk after vaccination, and also functional neutralizing antibody ability in human milk after vaccination. I usually, if given a choice, would recommend vaccination during pregnancy to provide greater and more durable passive immunity through the transplacental transfer, although we do think that there is some benefit from vaccination and lactation for the newborn. Lastly, I do want to say, in the age of emerging variants, that vaccination does appear to produce cross-reactive immune responses against various SARS-CoV-2 variants of concern. This paper of ours was published back in May 2021. So the current variants at that time were more the alpha and beta variants. And we did demonstrate that after maternal vaccination, there was good cross-reactivity in both the serum of pregnant individuals, infant cord blood, and breast milk cross-reactivity against different variants of concern at that time. And we're continuing to evaluate whether there's good cross-reactivity against emerging variants such as Delta and Omicron. And interestingly, a measure of T cell response over here on the right also, T cells seem to be less susceptible to different variations in the spike protein and do have great preserved cross-reactivity against new variants. Lastly, I have to say one more thing about variants that this is another reason why we actually recommend boosters in all pregnant people 12 years and older and who are 5 months from primary vaccine series, is that the booster dose does lead to greater immediate immunity and it expands the breadth of response to cover new variants. So after a third dose of vaccine, this is data from non-pregnant and pregnant individuals, whereas you get almost no response to Omicron in terms of neutralizing antibody. This gets raised significantly after booster vaccines. And the last note I want to say is that vaccine-induced T cells do remain cross-reactive against the Omicron, even 8 months after initial vaccine. So a reason to vaccinate. And at this day and time, although many of my colleagues asked me, a second booster is not necessarily recommended because of pregnancy alone, but by the common reasons, including age greater than 50 or significant immunocompromise. And so the last key counseling messages for vaccination pregnancy that I use clinically is that explaining the risks of non-vaccination and this severe COVID-19 disease in pregnancy, talking about that the safety of vaccination, which is not associated with increased risks of miscarriage, stillbirth, birth defects, or worsening maternal side effects. And also informing patients that vaccination during pregnancy provides passive immunity to the neonates and can reduce the risk significantly of infection and severe disease. So with that, I'd like to thank you and open up for any other questions or concerns. Thank you very much.